Lung cancer screening programs have improved the detection of pulmonary nodules, but the presence of cancer can only be confirmed with histological analysis. This often requires the resection of the nodules from the lung. This resection is typically performed through video-assisted thoracoscopic surgery, which is a minimally invasive surgical technique that uses a specialized camera and surgical tools to remove the nodule from the lung. However, the very large lung deformations following a pneumothorax, which is the deflation of the lung, make the localization of the nodules very challenging. Existing localization techniques such as hook wires, dyes, or even manual palpation have strong limitations. It is in this context that an alternative localization technique based on intraoperative cone beam CT images has been proposed at the Rennes University Hospital. The nodule is identified and delineated in the CBCT image. An augmented fluoroscopy is used to facilitate its localization. The problem is that some nodules are not visible in the intraoperative image. Also, it would be best to avoid the radiation from fluoroscopy. We then propose to compensate the lung deformation during VATS in order to estimate the position of pulmonary nodules in the intraoperative image. There are two main sources of lung deformation during VATS: a change of patient position and a pneumothorax. For this reason, we introduced an additional CBCT image, and we proposed to compensate lung deformation in two phases, one for the change of pose and one for the pneumothorax. Our method combines a freeform deformation transformation model for intensity-based image registration and a proelastic biomechanical model of the lung that behaves very much like a sponge, with air flowing through an elastic matrix of pores. The segmentation of the lung from preoperative data is first used to build a finite element mesh where the position of the nodule is well known. For the change of pose deformation compensation, rigid registration is first performed over the spine, followed by elastic registration based on freeform deformations, but the lung is only partially visible in the intraoperative image and the complete deformed lung geometry is unknown. Therefore, the partial deformation is extrapolated using our biomechanical model, where imposed displacements are applied to the nodes inside the field of view. The obtained solution represents the complete lung after the change of pose. For the pneumothorax deformation compensation, we used imposed displacements at the airway inlet, contact conditions with the thoracic cavity and diaphragm, gravity, and a homogeneous positive air pressure at the lung surface with allowance for air evacuation. The model parameters are estimated using an inverse problem formulation, where different configurations are simulated until the distance between the predicted lung surface and the intraoperative lung surface is minimal. Experimental results suggest the feasibility of our proposed approach, with average prediction errors of 10 mm across clinical cases. Finally, to avoid any radiation from fluoroscopy, we plan to project the predicted nodule position directly into the endoscopic view, and we have obtained funding for a new phase of this project.